Hello everybody, welcome inside the broadcast booth. My name is Brian Wright, National Keynote Speaker, CEO of New Patient Group, and the founder of the Dr. Diamond Club. Special welcome to our clients that are on today, as well as some other special guests that we're having join us too. Looking forward to having Dr. Blevins come on here momentarily. She's awesome at what she does. I know today's going to be a great webinar, and we're going to be talking about Invisalign sweet spot cases, certain patient selections to ensure efficiency and profitability, and looking forward to getting started. If you guys could switch the screen for me, we are going to talk a few company updates for our clientele that are on today. Go ahead and switch the screen there to the next one. Our first one, our Dr. Diamond Club podcast is launching to the public nationally and really globally for that matter on iTunes and other places you can listen to. Dr. Blevins has been a guest, and what the Dr. Diamond Club podcast is, for those that do not know, is basically we are just bringing in national leaders, whether they be clinicians or just business CEOs, to give away good, solid advice to help grow your practice. So we ask that you subscribe and download that, and I think it'll bring a lot of benefit to your practice and your team. If you could switch the screen for me. Our client mastermind meetings, for those who don't know, these emails have gone out. They will be on the last Thursday of each quarter. So this quarter is going to be Thursday, March 29th, 7 p.m. Central. Everybody, I very much encourage you, come to these live events so all of our clients can get together, discuss ideas, and just, again, like-minded people trying to grow at record levels, and I think you're going to get a lot of benefit out of that. So the last Thursday of every quarter at 7 p.m. Central Time, in your practice growth platform, the login details are there. So we probably will not send out emails with the login details unless you happen to be a member that's not on the practice growth program. You will get those emails. So again, coming together, like-minded people, I think we're going to get a lot of benefit out of that together. So make sure to come to those live events. Next screen, please. So a few more. So our next month, Eric Field, the Chief Operation Officer of New Patient Group, will be the keynote presenter, and it's going to be empowering the chairside assistant to maximize Invisalign efficiencies. He will be talking about that. And again, that will be Friday, March 16th. Remember, the third Friday of every month, we have our live events, whether they be clinical or commercial business related. Eric Field worked for Align Technology for many years and is absolutely awesome at what he does, so you will get a lot out of that. Again, all these obviously are going to be housed and recorded inside your practice growth platform, but again, I want you to show up live. You're going to get more out of them. And make sure to show your staff these as well, and watch them over and over again. Get as much out of them as you possibly can. So looking forward to that great event. Switch the screen for me, please. Just a little bit around the country. Eric Field just finished up talking at the Association of Dental Office Managers. That went really well. We got a lot of really good feedback on that. And he'll be in Buffalo, New York next month as a keynote speaker for an Align Technology event put together by a strategic account manager over there on the East Coast. For those of you who don't know, I will be writing articles for the Benson Koppel resource this year, and I will be the keynote speaker to the Association of Dental Service Organizations in April in Austin, and will be a keynote speaker next month in Baltimore, Washington, an Align Technology event that another strategic account manager has put together for us. So just wanted to let our clientele know a little bit what's going on with the company, and go to the next screen, please. So a special offer today for the participants that are non-Dr. Diamond Club members. If you call us or schedule your consultation today, we are offering a $100 off discount every single month of what the normal fee would be with no contracts. You'll get a mystery call and analysis, as well as a comprehensive practice analysis plus a video review. Basically what we'll do is go over it and do a video analysis of it and send that back to you so you can watch the video. So we look forward to you guys taking advantage of this offer. If you could switch the screen for me, please. So we're going to introduce Dr. Regina Blevins. I have had the great benefit of becoming a good friend of Dr. Blevins for quite some time now. She is the lead clinical advisor of the Dr. Diamond Club, and she's also a New Patient Group client. She is one of the leading Invisalign team providers in the world, an Align faculty speaker, speaks all over the country, and is just absolutely great at what she does. She's the owner of Minnesota Orthodontics. They have multiple locations throughout Minnesota, and a very forward-thinking mind that I'm excited that she's here to give away her knowledge today. So take notes and apply these principles to your practice. There's no doubt it's going to help you. And for those that did not hear, We do want you to keep all your microphones on mute today, and if you have any questions, simply use the chat feature, and we're going to be monitoring that, so we will jump in as necessary and let Dr. Blevins know what those questions are. So again, I am proud to turn it over to Dr. Blevins at this time. She is going to give a great presentation today. Thanks for listening, and hope you guys enjoy. Dr. Blevins, take it away.
Well, I hope everyone can hear me clearly. I'm going to say good morning, even though I don't really know where you are. And that's, I think, the beauty of a platform like this, because I'm out on the West Coast today and it's morning and I'm having a cup of coffee and I'm going to share some tips and pearls with you today. But no matter where you are, you can join in and come to the webinar today and give us some feedback on how it goes. And I hope you get a lot out of it today. Brian went over some of the credentials that I have. I think one of the ones that I just want to highlight here is that my associates and myself have done over 3,500 Invisalign cases. So we really have a deep pool of water that we're drawing from, and I plan to share some of those insights with you today. I do need to tell you that at this webinar, I'm not speaking on behalf of Align Technology. You'll get my candid comments and opinions, and Align Technology may not endorse my statements or opinions. So anything you hear today, you're responsible for how you use it, and I hope you get great benefit from it. But I just want to start with saying that I've noticed most doctors go through a very similar progression when they start learning about aligner therapy. You typically will get on board, be very excited, do some simple cases, have some success with that, and then you'll run into some setbacks or hiccups and maybe get a little bit discouraged. And then you'll go to a conference or you'll talk to an orthodontic colleague and you'll get encouraged again. Maybe you'll find a patient that forces your hand and will only accept aligner therapy. And then you get a little bit more competent and we'll start doing some cases and have more success. And then as time goes, you'll branch out and start doing even more complex cases. That's natural. The small setbacks, I don't want you to get discouraged about. Everybody has them. But our job with the Dr. Diamond Club and the clinical presentation is to try to short circuit that learning curve and get you to competence faster and more comfortably. Here is a recorded webinar from the Invisalign Academy site that I would suggest that you all watch, even if you're fairly proficient with aligner therapy. It's by Dr. Bart Iwasuki. I'm sure I'm butchering his name, but if you go to the doctor clinical site and go under Academy and search for presentations by Bart, this one is worth your hour's time, hands down. It will give you a systematic way to approach a ClinCheck. I find that one of the things that intimidates doctors is when they see a ClinCheck, sometimes they don't even know where to start with how to take it from that raw canvas framework that Align gives you to a finished product that will get you the clinical results that you want in the end. And this webinar certainly will give you a good starting point. I've also found that it's a great starter for a doctor that is getting to a point where he has or she has so many ClinChecks that you need to have a staff person help screening you and doing some of the basic setups. So if you start with your staff person watching this webinar, then that gives them that initial basis on how you are going to approach a ClinCheck. Today's focus is going to be on not just doing some clinically excellent cases, but how can you do this and be profitable? And let's face it, as much as we are altruistic and want to help our patients, we can't stay in business if we can't stay profitable. And one of the big stumbling blocks for doctors on this journey is the larger cost of entry in doing aligner therapy. So profitability with aligner therapy really breaks down, I think, into two basic categories. One is efficiency and one is how you manage your cash flow. Our efficiencies that we realize with aligner therapy is a much reduced bond appointment time. Putting attachments on in our office is much faster than even doing an indirect bonding. We certainly have very few, in most cases, no emergency visits with aligner therapy. And most of our aligner patients have many fewer appointments than our fixed appliance patients. And we've developed a protocol where we have appointment times that are half to 1/3 the length of our fixed appliance appointments. Now, the cash flow, probably the main way to enhance your cash flow with aligner therapy is to make sure that you're doing enough of a volume to get that lab fee at the most reduced rate that you can. Now, it's a bit of a stomach churn to go through that period of time when you're ramping up to get to that level. But if you can manage to get over that hump, then you'll never look back, because once you're only paying 60% lab bill at that 40% discount rate, you'll maintain that level because your proficiency will be at that level by then too. And certainly we can see many more patients without adding any additional staff. And the staff that we have added when our volume has increased have been staff that can work and be assistants to our assistants. So those staff that we've added have been not necessarily at the licensed dental assistant level, but more auxiliary staff that actually can help. And I'll go into that a bit more in a minute. We used to have a dedicated lab technician, and when she retired, we didn't replace her. With our office being about 60 to 75% aligner therapy, we found that we don't need a lab technician in the office anymore. We do offer a discount for pay in full, and we find that a certain percentage of patients will take advantage of that, and that actually helps cover some of the lab bill for the other patients that finance their treatment. And last but not least, realize that your Invisalign invoice is not due net 30 days, it's due 60 days. So what we will do in our office is split our down payment from we're paying about $1,000. So we will get $500 down at their contract signing. That's when we've scanned and we're getting their case submitted. And then the day that their aligners are due to be inserted, which is typically about 4 to 6 weeks, we get another $500. So our lab fee is collected before the 60-day invoice is due to Align. Align announced this year their new lab fee tiers for increased volume, and talk to your sales rep to get more details on this. But we really started realizing the true profit of Invisalign therapy once we got to a higher level tier group. How do you measure the profitability of a case? That is a question that we asked ourselves. And what our practice decided to do was have one of the staff people take a clipboard and a timer, and literally we started timing things that we did. How long did it take for a fixed direct bond? How long did it take for a Invisalign attachment appointment, an Invisalign fit assessment appointment, an Invisalign D-bond, a fixed D-bond? And literally, we have electronic charts, but think of it in your mind as pulling charts. And we also went back, and our practice software will tell us when a patient checked in and when a patient checked out of a chair. And we went back and we did comparisons of both fixed and aligner therapy. So you might ask, what were our results with this? Well, in our fixed appliance therapy, this is just an average case that we looked at, where we counted the visits, what the time per visits were, and we came up with what our profitability was, not only per visit, but per hour. And as you can see, we were netting around a $800 figure per hour. But the surprising thing was, with Invisalign therapy, even with our lab fee, our net per visit was higher, but what was dramatic was our net per hour was double. Now, that was because we were allowing 30 minutes for our routine Invisalign or fixed case adjustments, which included untying the patient, going to the sink to brush, coming back, doctor checking, and getting tied back in. And with Invisalign, we were only allowing 20 minutes, and very often it was noted that the patient was in and out in less than 10 minutes. One big factor was the patients weren't going to the sink to brush, which could take upwards of 5 to 8 minutes, depending on whether or not the patient's parent was helping or whether the kid was fooling around at the sink, etc. So with these measurements now, we felt that we had to make some significant changes in our scheduling structure at our office. So let's look at case one and how this applies at our office now. So you have Kristen. She's a 45-year-old female that came to our office with a chief complaint of having a protruded tooth on the upper arch. Looking at her x-ray, it's not contributory. Her Ceph, very normal. And for our diagnosis for Kristen, what we came up with was she's class 1 dental occlusion, class 1 skeletal occlusion. Her overbite and overjet are essentially within normal limits, and she has mild upper and lower crowding. This is what I consider a sweet spot case. We don't have AP correction. We have mild aesthetic concerns, but functionally a fairly decent occlusion. A little bit of a narrow arch form. And then what we prescribed for Kristen was upper and lower Invisalign aligner therapy. Our treatment plan is going to be essentially uprighting the buccal segments, a little mid-arch expansion, and we developed a ClinCheck around those treatment goals. So this is what came back in our first ClinCheck. okay? One thing that I've found that adult patients especially don't like is when the anterior teeth have different attachments. If they both have attachments, it doesn't seem to bother them that much. If neither have attachments, they love it. But one tooth having attachments and one not tends to bother my adult patients. So we modified the ClinCheck somewhat. I thought with big, broad anterior teeth that really don't have a lot of dramatic root change, I would take the attachments off the left central incisor, and I added slightly beefier rectangular attachments for control of the laterals. And that's really the only modifications that I made to this. And I'll play this ClinCheck through for you, just so you can see it's arch widening and bringing in the lateral and unraveling the lower anterior crowding. Very doable case. A little bit of proclination and torque on the maxillary anteriors, but mild. The IPR that we added on the lower was for a black triangle. The key here is make space around this lateral incisor before it ever starts to move. One of the things that the software tolerances are tight in that it will allow the teeth to skim each other. And for a tooth, for example, like this one that moved, if you don't have space with either IPR or visual space with expansion, you will get collisions and those teeth will not move. It will cause the tooth not to track and you'll end up with a revision. So here we have Kristen at the end of her treatment with her chief complaint addressed and her upper and lower teeth nicely aligned and her arch form corrected and her buccal segments uprighted. In summary, Kristen's treatment took 6 months. She had 24 stages of upper and lower aligners, and we did one revision of 2 aligners to tighten the lower anterior contact where we did the IPR. She had a total of 4 visits, and let me quantify that for you and explain that. We count our visits not as the new patient visit, because all our patients get that visit. And at our new patient visit, we take all the records, present the treatment plan, financial arrangements, and start the case. That's our goal, is a 1 visit start. So in Kristen's case, we did a 1 visit start. The 4 visits include her attachment visit, 2 aligner fit assessment visits, and a D-bond visit. Our fee for Kristen, since it was a short treatment time and very doable in what we thought 6 to 8 months, we charged a fee of $4,100. We paid a lab fee of $1,000. And I'm putting in parentheses, if you were paying Align's top lab fee, you would pay about $1,800. So our net per visit for her was $775 a visit. With those appointments that we talked about, we allow 20 minutes for attachments, 10 minutes for fit assessments, and a 20-minute for a attachment removal debond. What that nets out per hour is $3,100 per hour, which is quite profitable. Let's look at case 2. This is Sean. He's a teenager with some crowding, and he has Non-contributory x-rays, pretty Joe normal. And measuring out his Ceph, you can see he's ever so slightly class 2 A and B, but other than that, very normal. Our diagnosis for Sean was a mild class 2 malocclusion, class 1 skeletal, a moderate deep bite, tight on his overjet, and he has mild crowding. Fairly normal arch form and a slight midline discrepancy. The treatment for him, we prescribed upper and lower Invisalign aligners, class 2 elastics on the right to settle his bite, and he had a Bolton discrepancy, so we are going to do some IPR. Now, one of the things with deep bite patients that I find helps the technicians visualize what we want to do is using the intrusion amounts as a ratio. So looking at Sean's smile arc, I really wanted to keep his upper incisors pretty much where they were. So I used the ratio of 0/100, meaning I want 100% of the deep bite corrected with intrusion of his lower anteriors. So his first ClinCheck came back, and you can see, again, we've got root control attachments on central incisors that really don't have a whole lot of root movement to happen. Now, again, one of the things in the software is there's a threshold that these optimized attachments are triggered at. And for Sean, I'm sure the lowest level of triggering threshold was met. And as a clinical doctor, I decided that I thought that tooth could move without that attachment. So we'll end up taking that one off. And I also decided to put an anchorage attachment on the other incisor, and they didn't add the class 2 elastic, as you'll see here on the right side. So this is the first ClinCheck. And you'll note the missing class 2 elastic that I'd asked for. So this is just showing if you don't use the Bolton graph in the software, it's a very handy tool to let you know right away that you need to address a Bolton discrepancy, and I use it all the time. But this is the approved ClinCheck that we worked with. So notice no attachments on 8 and 9, the extra anchorage attachment on the lateral incisor. I added the class 2 elastic on the right side, and these two attachments down here, I changed from rotation attachments to anchorage attachments for the deep bite, and I'll show you that in a little bit more detail. Okay. So here's what we have. We have the attachments that we changed on the front teeth, 8 and 9. We've matched the extrusion anchorage attachments on the laterals. And I've added my IPR for my Bolton discrepancy. And one of the things I noted in the ClinCheck was the round tripping of 8 and 9. Now, if you notice something like that and you don't think it's necessary, it's very easy to add in a verbal comment or in a written comment to not do that. And that's one of the things we added to get a little more efficiency in this ClinCheck. The other thing I pointed out, and I'll show you here in detail, is the rotation attachment that we changed to an anchorage attachment. And this is part of G5 protocol for Invisalign. There's webinars on YouTube as well as on the Invisalign Academy that will explain to you why you need these gripper attachments, these anchorage attachments, more so than a rotation attachment. And basically what these attachments do in a deep bite case is hold the aligner in place while the plastic pushes the lower incisors down. You also get some extrusion of the bicuspids. So this is what Sean looked like in 9 months, and his deep bite is resolving nicely. We've got improvement in his A and B. And this is just to show you what we programmed in and what we actually got. And it's very close. I typically plan that I'm going to intrude on the ClinCheck about a 0.5 millimeter or 1 millimeter more than what I expect to see in the mouth. So I do a slight amount of over-engineering to ensure that I get the deep bite correction. Now, here's another hint on looking at deep bite cases. If you angle the ClinCheck photos or the ClinCheck model, you can look at it more realistically like it's in the mouth. And you can visualize the smile arc. When you populate it at the ClinCheck, it comes up as a very static, very straight smile, but I like to rotate it down when I'm trying to decide how much of each arch to affect the intrusion on. And this just shows you how little upper anterior intrusion that we had in this case, and that it was all focused on the lower anterior intrusion. We did have a revision, actually 2 of them with Sean, where we needed to do a little bit of contact tightening. Now, here's a hint on contact tightening. I don't usually like the full arch closing chain tightening. I will specifically request tightening in the areas where contacts are open. What I've found with the closing chain tightening is sometimes teeth will intrude if that tightening happens where contacts are already tight. And here is Sean finished in 11 months. Again, very mild AP correction, mostly anterior deep bite correction. That's why I would consider this a very efficient sweet spot case. And in summary, for Sean, we were able to finish his treatment in 11 months with 35 stages of aligners, with 2 revisions of 3 aligners each for contact tightening, for a total in our office of 7 visits. We paid a lab fee of $1,000 and netted about $614 a visit. A 20-minute attachment visit, 5 10-minute fit assessments, and a 20-minute debond for a net of about $2,860 per hour. Case 3 is a young gal named Martha, and her chief complaint was an anterior open bite. And as you can see on her Panorex, she does have some generalized spacing, and that's, again, makes this a case that's a little bit more straightforward than a true skeletal open bite. So we have a large A and B. So she has a class 2 component here as well. But that A and B is also influenced by the amount of flaring on her maxillary incisors. So our diagnosis for Martha is, I called her a class 1 malocclusion based on the molar relationship, and a class 1 skeletal. Again, I feel that the large A and B was mostly from procline teeth. She had a moderate anterior open bite and some spacing, fairly nice broad arch forms, a little bit of a midline shift, and we prescribed upper and lower aligners for Martha. And we're going to do some anterior extrusion on the upper, some slight posterior intrusion. And this is Martha's first ClinCheck that came back. Couple things I want to point out to you. The threshold in the software wasn't triggered for extrusion attachments, but that doesn't mean that you don't need them. So the ClinCheck that we approved, I added extrusion attachments on all her anterior teeth. Okay. I also added some mild class 2 elastics, 2-ounce 5/16 elastics to help the tray pull back and help with the retraction of the maxillary anterior teeth. So what we have here, comparison-wise, the extrusion attachments added on the anteriors, the class 2 elastics, and that increased movement, added extra stages onto her ClinCheck. But I think that 34 stages is still very reasonable for a case like this. So here is Martha, and as you can see on these progress photos, her anterior open bite has closed down nicely. We had a 4-stage refinement, again, to tighten the contacts. And in 19 months, Martha has positive overbite. And at this point, we were holding for a while and did her progress x-rays and Ceph, and things looked very nice and much improvement. One thing I didn't like at this point was the torque on her anterior teeth. So we did a second revision to finesse the torque on her anterior teeth. And you can see that happening here. So that refinement took 17 weeks and did a nice job in expressing torque and improving that position of her anteriors. So in summary, Martha's treatment took 11 months. She had 34 main sets of aligners. We did 2 revisions for her. One was contact tightening aligners with 4 stages, and then 17 stages of aligners for torque. And I will mention to you, if you're wondering, I do weekly changes, if I forgot to mention that to you. So for visits for Martha, we had 8 visits, and we netted about $575 a visit. She had a 20-minute attachment appointment, 6 10-minute fit assessment appointments, and a 20-minute debond for a net of $2,700 an hour. So this is our last case we're going to look at today. This is an example of what you could do with a younger patient phase 1 treatment. Jason came to the office. He was just shy of 10 years old, and the chief complaint was his underbite. And as you can see on his x-ray, everything is coming in. He's what I would call middle to late mixed dentition. So we diagnosed him with a class 3 malocclusion, class 3 skeletal. We did a look at the CO-CR discrepancy and could get him end to end. He had some moderate upper and lower crowding, which meant not the anteriors necessarily, but we needed to make space for erupting canines. He did have a broad arch form and a slight midline discrepancy. For his treatment, we prescribed upper and lower Invisalign aligners. One of our chief goals was to make room for canines and to run a light class 3 elastic for his AP correction. Again, I start with a 2-ounce 5/16 elastic. Now, one of my comments for the ClinCheck for Jason was to apply facial crown torque simultaneously with advancing his teeth. Now, I like to make sure that if I want 5 degrees of torque, I will ask for 10, because I find that I don't get expressed the total amount of torque that I typically ask for. So his ClinCheck came back at 25 stages. Now, for Jason, since we don't have a lot of unraveling to do on the anterior teeth, and we want to slowly advance his anteriors, we did a 2-week change on him. So 25 stages at a 2-week interval. And here is his ClinCheck. So he's running a mild class 3 elastic, and we're proclining his upper anterior teeth. Okay, a little bit of retroclining of his lower anteriors just slightly. I did build up some turbos on his primary teeth to keep him out of occlusion while we jumped his bite over. I've found now that you don't have to glue those onto the teeth. You can just ask for occlusal attachments and they'll act as turbos, and I don't typically fill them. So here is Jason after 8 months of wearing his aligners and running his elastics. And as you can see now, we have some positive overjet on his anterior teeth. He's got a fairly reasonable interincisal angle, and his A and B now is at 1. And 12 months of treatment, it's holding nicely, and we see a canine starting to erupt. So what we did at this point is scan for transitional aligners. Now, if you ask Align, excuse me, for transitional aligners, they won't know what you're talking about because that's a term that I use, not they use. But basically what that is a revision that I scan for, that I put very slow movements in, that really acts as a retainer between phase 1 and phase 2. The nice thing about this is that you can order enough that the patient can still continue to change every week or every 2 weeks. I can have elastic slits put in them so that he can wear rubber bands at night, and I have them wear these transitional aligners at nighttime. So this is his ClinCheck for his transitional aligners. And as you can see, I'm running asymmetric elastics now, so I'm trying to get some effect on the midline correction. Another hint on phase 1s is that typically the technicians will close all the space. If you want to remain, or you want space to remain for the erupting canines, you'll need to tell them where you want space to remain and ask them not to close that space. And these green squares are the areas where space has been left for tooth eruption. Now, another thing, when a baby tooth is lost, I don't get excited about it because that area of plastic acts very much like an eruption well for the emerging permanent tooth. So I don't jump right away and do a scan and change things. I know that later, when I'm in an active period of aligners again, I can finesse all of that. And occasionally, I'll have a patient come in where the aligner isn't fitting because a permanent bicuspid or canine has erupted a little buccal or lingual. And then what we simply do is take an acrylic burr, relieve the aligner where that is happening, and have the patient continue wearing the aligner. So I really try to hold off as long as possible before I do another scan and get more aligners. So at this point, Jason's phase 1 goals were met, and he's had 6 office visits. We were able to jump the anterior crossbite, make some additional room for canine eruption. Now, have we controlled mandibular growth? Who knows? All I know is he isn't worse than he was, and it seems to be holding. And I think sometime down the road, when people look at data and they can measure cephs and superimpose them, we may get more answers on what some of these things can do. But I think at this point, that's kind of an unknown. But as you can see on his Panorex radiograph, we've got canines erupting nicely, and we're now waiting to the start of phase 2. So at his next visit, he's ready for phase 2. We've had so far approximately 12-month phase 1 of 6 visits. He's been in the nightly wear of transitional aligners for approximately 9 months. And during that time, he had 2 visits for, at this point, a total of 21 months of care in our office with 8 clinical visits so far. So we started phase 2, and this is our phase 2 ClinCheck. And that's going to consist of bringing the canines down, again, continuing the class 3 elastics for his growth. And I'll show you the other side here. Now, the big decision here is whether or not to run a button on these canines and a triangle elastic to bring them down at night. And for Jason, I elected not to do that to see how they traction down on their own. But if this were a class 2 patient and I was needing to run an elastic in the canine area, I would probably put a button on that tooth to aid the extrusion of the canine. So at this point, Jason has about a 30-month treatment plan. He's had 25 phase 1 aligners with 6 visits, 30 stages of transitional nighttime wear with light class 3 elastics and 2 visits, and additional aligner movements for phase 2. We're anticipating 5 total visits. So in a case like this is a long treatment plan, a phase 1, phase 2. We feel reasonably comfortable that we're going to finish this up in 13 visits. We do charge more for phase 1, phase 2, and we do charge for the full fee when we're doing it with aligner therapy at the beginning. And so we figure in our lab fee. We net about $392 a visit on a case like this, and a net of about $1,800 an hour. So let's just go back originally and look at our data from our fixed and Invisalign on the old protocol. Remember, we were netting about $800 an hour for our fixed, and for a routine case with Invisalign, not a lengthy, protracted phase 1, phase 2, but a regular Invisalign treatment, we were netting about $1,300 an hour. So what I want to point out to you here is it's very important for you to look at your efficiencies for your number of visits and how long each of those visits are. And some of the things that made us successful in shortening our visits for things like attachments and take-home instructions for retainers at D-Bond is we are utilizing videos, and we have videos on iPads so we can get our patient out of the clinic chair, or as some people like to call it, the money chair, and either back in the waiting area, or in some of the offices that we have a little alcove sitting area where they sit with the iPad and they watch the video on wear and care, or they watch the video on retainer instructions. And we don't do that anymore at in the clinic chair. So that way we can get the patient out of that chair and another patient into that chair. And the assistants do the things that assistants are licensed and need to do. Like our ancillary assistants, the ones that aren't licensed, will seat the patient. And in a case of fixed, even, we've gotten more efficient because that person will seat the patient in the chair, brush the patient's teeth at the chair, and then when the assistant is ready, well, and that actually typically takes about 3 minutes, and they aren't untied, okay? But they will get the mouth cleaned up, and the assistant comes over and gets started and doesn't have to have that gap of time where the patient gets up out of the chair, leaves the chair, goes to the sink, and comes back, okay? So we've gotten very good from measuring what we do and watching our procedures that we keep the patients in the clinic chair the shortest amount of time possible. And the wonderful thing about the videos is that you can also email them home or email them to a parent that didn't come to the visit and get that kind of continuity of care and interaction with the family that we didn't have before. Here's a summary slide on pearls on how to get a ClinCheck that you want. We've developed a list of copy and paste instructions. So if you find yourself repeating over and over again typed in comments, develop a library of those comments that you can simply copy and paste in. And we find that that's a real time saver. Also, a list of ClinChecks. Excuse me. For example, you have a deep bite case that worked out very efficiently, and that's how you like your cases handled. We will reference those in the comments when we submit the ClinCheck. Please see case ID number. I like my setup like that. Again, it's a way to get what you want, a visual way for the treat technician to see what you want, and an efficiency in doing your ClinChecks. We will also use often right and left comparisons. I like the way the canine was extruded on the left. Please mimic that on the right. Again, a shortcut way of explaining things. We also tell them approximately how many months we think a case should take. So we'll say typically our deep bite cases like this treat out in about 12 months. So that gives the technician a guideline of how fast you think the teeth would move. And then another real asset in our practice, in the volume level that we're doing now, we have what we call our ClinCheck coordinator that cleans up the ClinChecks for me. For example, they look at the treatment plan I've written, and if I say I want class 2 elastics and the ClinCheck came back and doesn't have class 2 elastics, they will add them in, or they will give the instructions and get that put on for me. So I don't see the ClinCheck until my ClinCheck coordinator has the treatment plan, a checklist completed, that 80% of the intrusion did happen on the lower anterior teeth. The elastics were added, et cetera, et cetera. So I want to leave you at the end of this webinar with this thought. If you're going to do aligner therapy, rather than fighting and struggling, focus your energies on being the absolute best doctor at aligner therapy that you can be. And I gave up a long time ago being, for lack of a better word, disappointed that things were going this direction. And once I've learned how to move teeth with aligners, I have to tell you, the disappointment has changed to pure excitement. And not only excitement in our practice growth, but in excitement in the efficiencies and the profitability that we've seen in our practice. Brian?
Great job, Dr. Blevins.
How are you doing?
Yeah, great job. Hope everybody got a lot out of that. I think there was a lot said today that the orthodontists on the call got out of it, and as well as the GPs. So wonderful job, Dr. Blevins. One of the pleasures that Dr. Blevins has been as a client is how forward-thinking she is, and just it's kind of out with the old, in with the new. So I think that last message you had, hope everybody takes that to heart. If there's any questions right now, we didn't see any typed. If there's any questions that anybody wants to unmute their mic and actually just verbalize, now would be the time to do that. So just give it 1 second to see if we hear any voices come on with questions, and if not, we'll wrap it up.
Brian,
yes,
I just want to say a few words about the next clinical webinar.
Okay.
Today I gave you a taste of 4 cases. I'll admit they weren't terribly challenging cases, but I wanted to give you an overview of how we might look at cases during these webinars. The next webinars will look at specific case types and dive really deep in how to get an efficient ClinCheck and get the end results that you'd want predictably. So anybody out there that's listening, I look forward to seeing you at the next webinar, and I hope that this can make an impact in your practice.
Fantastic stuff. To our clients out there, appreciate you joining. This will, of course, be recorded, spliced up, and housed in your growth platform in the continuing ed section. And for those of you that aren't our clients, take advantage of that offer that we threw out there earlier on. And we look forward to everybody joining next time. Thanks for joining, everybody. We'll talk to you soon.